Welcome to the Cardiovascular tutorials. Aneurysmal disease and the endovascular treatment of standard and complex aneurysms has increased over the last 3 decades. Following the insertion, the fixation, and seal of an endograft, there is a role for long-term surveillance, as these patients can have multiple complications develop with time. Amongst these complications are endoleaks. This term endoleak was first described by Dr. Geoffrey White and Dr. James May from Sydney, Australia. Endoleaks have over time been divided into 4 types, with an additional type added more recently, type 5, each with its own unique definition. A type 1 endoleak is perhaps the most concerning for us, and it can be divided into type 1A or a 1B, depending on whether the flow is at the proximal or the distal end between the sealing vessel wall and the graft. Type 2 endoleaks, which this talk will focus mostly on, is when, as a result of increased pressure in the aortic branches within the seal zone, blood flows back into the sac. A type 3 is when a defect, a fracture, or a misalignment of the EVAR graft results in a leak into the sac. Type 4 occurs due to porosity of the EVAR graft material, and this can occur early on or at a later stage in the lifespan of the graft. And finally, type 5, which is commonly referred to as endotension, is thought to be due to referred pressure from the graft and is usually a diagnosis of exclusion. Type 2 endoleaks, as previously defined, is a filling of the aneurysmal sac by a native branch or a tributary of the vessel treated, which over time can result in native aneurysmal sac size growth, sac pressurization, and even rupture. The natural history of type 2 endoleaks is not well understood. However, we do know that the incidence can be quite high following an EVAR, as high as 40%. It is also the most common type of endoleak, accounting for up to 50% of all different types. The risk factors for type 2 endoleaks can be divided into major and minor. Arco et al. In the JET of 2001 identified that an IMA with a luminal diameter at origin of greater than 3 millimeters is a strong risk factor for patients developing a type 2 endoleak. In addition, the patency of 2 pairs or more lumbar arteries has also been shown to be a risk factor. Other minor risk factors include aneurysmal diameter size, aneurysmal volume, and lack of mural thrombus, as reported by Gallagher in 2012. The long-term effects are not well understood, but we know that there are some that show sac size growth, and a series published by Sidloff et al. In the BJS of 2013 showed a rupture risk of 0.9%. This, however, was not in every case associated with mortality, and it's important to remember that whilst this is technically a rupture, the mortality associated with such an event is not clearly understood. Overall, this risk is very low, and there is some debate about how to manage type 2 endoleaks. The general consensus amongst specialists is that if you find a persistent sac size growth of greater than 5 millimeters without any other cause, then this warrants consideration of intervention. The management of this problem can be achieved by first appreciating the underlying pathology. Type 2 endoleaks have been quite accurately described to be analogous to an arteriovenous malformation, in that there are inflow and outflow vessels involved, and that the nidus of the AVM should be the main target of treatment. The treatment options, as with almost all conditions in vascular surgery, fall into conservative, endovascular, and open surgical options. The techniques that are at the disposal of the treating surgeon include embolization through transarterial approaches, transcaval approaches, and of course open surgical ligation and repair. Furthermore, involvement of a radiologist can also be helpful in attempting a direct sac puncture and embolization. In your pre-op workup for these patients, there is often a need to evaluate further with a CT angiography. Other investigations include an ultrasound and also a contrast or a bubble-enhanced ultrasound. Be sure to exclude through pre-op imaging other causes of sac size growth, such as another type of endoleak, and also assess the patient's risk of infection and the potential for graft infection to be causing the sac size growth. A thorough workup in these patients may be indicated with clinical, serological, and radiological parameters reviewed in a multidisciplinary setting. Let's first discuss transarterial options for managing type 2 endoleaks. On the day, your toolkit for this procedure will include your access catheters, which can range from standard to more designated shapes, your embolization catheters, which may be essential for accessing lesions given they have low profile and long length, and of course, your choice of embolant. These can be coils, liquid embolant, and embolization particles. The first step on the day involves a thorough diagnostic assessment, which includes a DSA via a pigtail of the suprarenal aortic segment in AP and lateral views. This allows firstly to exclude a type 1 endoleak, but also to identify all the mesenteric collateralization from the SMA and the celiac to the IMA, which can be filling the sac. The second step involves retracting that pigtail catheter back into the aortic graft and performing a DSA to exclude any type 3 or 4 endoleaks that may be appreciated this way. The third step involves cannulating the SMA to selectively diagnose a type 2 endoleak filling the IMA through the arc of Riolan, or the marginal artery of Drummond, or the meandering mesenteric artery. It is important to appreciate the anatomy in this region. The arc of Riolan is the anastomosis via the collateral branches of the middle colic and the ascending left colic, which lies more central along the root of the mesentery. Whereas the artery of Drummond is the connection between the middle colic and the left colic arteries. The fourth step is then to selectively cannulate each internal iliac artery on each side. That is, of course, if they have had sealing of the EVAR in the common iliac arteries. This can either be done from an ipsilateral approach or from an up and over approach through the EVAR graft, being mindful that this can be quite difficult to safely track a catheter up and over. Alternatively, puncturing the other side and selecting the internal iliac artery on the other side. This allows for delineation and identification of any iliolumbar arteries which commonly anastomose with the lumbar arteries feeding the aortic sac. There are also several other anastomoses that can be elicited, including the middle rectal artery anastomosis with the superior rectal artery, a branch of the IMA. All of this pre-treatment workup and diagnostic imaging will help identify the most appropriate method of treatment and help plan subsequent treatments if necessary. It is important to invest time in appreciating the anatomy and planning the best form of attack, as often embolization can preclude subsequent effective treatment strategies. Remember the goals of treatment. Identify the inflow and outflow vessels. Remember the treatment is to target the nidus of this endoleak and obliterate the AVM-like pathology. Whether it's a trans-mesenteric approach or a trans-iliolumbar approach, ensuring sac catheterization and performing a run in the sac, also referred to as a sacogram or an endoleakogram, can further give you a baseline to work with and help appreciate the full scope of the problem. And most importantly, it can offer a focused treatment approach which will obliterate the endoleak most effectively. Once a more thorough understanding of the endoleak has been achieved, through amalgamating information from preoperative and on-table imaging, then navigating to the desired target vessel through the sac can be achieved with your microcatheter. Once the targets have been embolized, the remaining sac can then be filled with coils. If unachievable due to limited intrasac maneuverability because of graft and sac space, then approaching the target through contralateral access could also help target the vessels. The existing literature and results of the transarterial approach can be summarized in the Sidloff et al. Systematic Review published in the BJS of 2013, which reports an overall 62.5% success rate, which was defined as no recurrence of a type 2 endoleak. The reintervention rate, however, has been reported to be as high as 20% by Sirac et al. In the JVS of 2012. Onyx embolization has some evidence behind it, particularly when the nidus can't be reached close enough, but would be suitable for an onyx as a liquid to dissipate and follow the flow into the nidus and the sac. Boissez et al. In the Journal of Cardiovascular Surgery in 2013 showed successful outcomes using onyx in 12 out of 13 patients, and Abularage in 2012 in the JVS, as far back as 1999, showed that onyx is a good option embolant for persistent type 2 endoleaks in the secondary intervention setting. While such a success rate may seem low, these procedures are generally considered to be low risk and can be repeated multiple times if necessary. The risks of a transarterial approach, whilst may be reported to be low in the literature, are very important in your consenting process and include the following: access-related complications, including bleeding, infection, and pseudoaneurysm; inadvertent embolization of end organs, including mainly the left colon, particularly if the SMA or iliolumbar approach is selected; and of course, risk of reintervention. Another approach that could be attempted when transarterial fails or as an adjunct is the trans-iliac paraendograft embolization technique, which has been given the acronym TYPE. This involves accessing the sac via a defect or a created space between the iliac sealing limb and the native artery. Pre-op imaging can help in identifying a minor gap between the common iliac artery and stent, and also, if no gap is identified, then selecting the side in which the shortest limb exists may help in this access. The first step in the described technique by Copy et al. Involves the use of a Python GC 9 French profile sheath manufactured by Medtronic. Introducing this over a stiff wire, which is previously placed in the aorta, and positioning the sheath tip at the junction of the distal edge of the iliac limb, and then using a glide wire to angle into the space between the graft and the native wall and into the sac. This is followed then by a 5 French sheath over the glide wire into the sac for support. Then performing a diagnostic endoleakogram to determine the anatomy and where the outflow vessels are is the next step. This will assist in subsequent navigation and coiling. Once confirmed and accessed, embolization can be achieved with either coils, onyx, or glue. On completion, confirm no further filling of the sac, and on the way out, remember to balloon the access limb to exclude a potential type 1b endoleak. And finally, a completion aortogram to confirm success. Results of the TYPE technique has been reported in 2 main series. The first description and results, published by Copy et al. In the EJVS of 2014 from Italy, showed successful treatment in 17 patients between 2009 and 2013, with 16 out of 17 successful cases. They also reported 2 complications. The first, colonic ischemia in 1 patient as a result of IMA embolization who required surgical bowel resection and had a 52-day admission, and a type 1b endoleak that required an iliac extension. The second series was reported by Sayed Emeli Renani and R.A. Morgan from the UK in the CVIR in 2016, and their promising experience of 4 patients in which onyx as an embolant was used in this setting. The next technique to discuss is the transcaval coil embolization, abbreviated TCCE. Although still very rare in this sphere of treatment, it has started to gain traction in the TAVI world as an alternative form of access. Early experience for this dates back to 2007 by Mansueto, published in the JVS, in which a TIPS shunt kit and a Calipinto needle manufactured by Cook Medical was used. And there is also the ongoing experience by the Hamburg group at TCE UHC, led by Thilo Kobel at the German Aortic Center. There are also experiences from Giles K.A., published in 2015, and also Gardini et al. In the JEVT in 2014. This initial technique, described in the literature, involves the use of a TIPS catheter. The described technique requires the following planning steps. 1. Preoperative imaging to plan the approach and access level at which there is the most proximity of the cava to the aortic sac. 2. A coaxial shunt kit and choice of embolant. 3. Orthogonal imaging or fusion, which could potentially be helpful. And 4. Intraoperative sac pressure monitoring. The operative steps involved are ultrasound-guided common femoral vein or internal jugular vein access with a 10 French sheath, concomitant arterial cannulation and aortography for identification of the endoleak and type is also necessary. Another technique described during this approach has been the use of intraoperative IVUS in the IVC to identify the level of most proximity of the aorta to the cava. A 5 French sheath catheter and needle is then introduced into the 10 French sheath, and the sac is then punctured under fluoroscopy. Confirmation of back bleeding or injection of contrast through the colapinto puncture needle can confirm access into the sac. This is followed by removal of the colapinto needle and advancing the wire into the sac, followed by a catheter to then identify and navigate to the location desired. Once embolization has occurred and further sacography confirms obliteration of the endoleak, remove the catheter and perform a final venography to confirm no aortocaval fistulation. A post-op non-con CT can be performed to exclude a retroperitoneal bleed. Mansueto et al. In the JVS of 2007 showed his 12-patient experience. He showed that in 1 year there was 11 out of 12 technical success, and 10 out of 11 showed no endoleak at the end of 1 year follow-up. Giles Walsh et al. In 2015 showed that in 26 patients, of which half had prior endoleak embolization attempts, had a 70% experience of no further endoleak at 1 year following TCCE. The Gardini experience in 2014 in the JEVT showed a 100% success rate in 26 patients, whereas the Thiele-Cobell experience in 15 patients showed 14 out of 15 successful results. Ultimately, this technique shows a mixed profile of results. However, it appears to be a viable alternative in patients who for whatever reason can't have the standard attempts at embolization. The alternative approaches to endovascular embolization of type 2 endoleaks include a direct sac puncture or translumbar approach, and of course, an open surgical option, which includes retroperitoneal laparoscopic ligation of sac branches or open surgical ligation and repair. In summary, the interventional options for treating type 2 endoleaks include transarterial embolization, transiliac paraendograft embolization, transcaval coil embolization, direct sac puncture, or open and laparoscopic surgical options. Thank you for watching the cardiovascular tutorials.